Bom dia a todos. Bem-vindo a esse Simpósio Internacional de Cardiologia, Pediátrica e Cirurgia Cardíaca, patrocinado pela Neonatal. É realmente um prazer receber os professores estrangeiros, os professores nacionais e, principalmente, os participantes de diversos estados que nos prestigiam. Vendo esse filme, eu me lembro que, em 2009, nós tomamos uma decisão de criar um centro de cirurgia cardíaca e um centro de terapia intensiva pediátrica voltada para a cirurgia cardíaca. Desde então, nós já fizemos mais de 3.000 cirurgias cardíacas com índices de sobrevida comparáveis aos grandes centros internacionais. Nós somos hoje um dos maiores centros de cirurgia cardíaca do país. Nós somos responsáveis por todas as cirurgias cardíacas da Secretaria Estadual de Saúde do Rio de Janeiro. Somos a única unidade privada capacitada a fazer isso. Portanto, é um contínuo aprendizado, e é por isso que esse simpósio internacional é tão importante, porque traz para a discussão ideias, experiências diferentes de outros centros e que só vai engrandecer o nosso serviço. Eu vou passar a palavra para a doutora Sandra, que é um dos sustentáculos do nosso programa, junto com a nossa fabulosa equipe, e ela vai dar continuidade e explicar um pouquinho como é que vai ser esse programa hoje.
Bom dia a todos. Obrigada por vocês estarem aqui cedo. Tem muita gente ainda presa no trânsito, né? Nós planejamos fazer um programa em que a gente mostrasse não só os nossos resultados, mas também que a gente conseguisse fazer um mix de um pouco de terapia intensiva, um pouco de cardiologia pediátrica e trazer especialistas que possam passar para vocês, principalmente, a experiência deles. Nosso objetivo é gerar uma discussão, tem gente aqui de outros estados, e nós queríamos gerar uma discussão para que as pessoas colocassem suas dúvidas, porque eu lembro, quando eu estava iniciando nesse ramo de cirurgia cardíaca, uns 5 anos atrás, né, Manuel? E eu tinha muitas dúvidas do que acontecia no nosso dia a dia com os nossos pacientes, e, às vezes, você não tem a quem perguntar, né? Então, às vezes, é só o nosso chefe imediato, às vezes você fica com casos que não resolve bem, às vezes você não acha as coisas nos artigos, nos livros, né? Que antigamente a gente tinha até mais dificuldade nisso. Hoje em dia você Google everything, né? E a gente, quando consegue conversar com pessoas que fazem isso, que têm uma experiência maior, que consegue ter lançar mão de outros meios, outras ferramentas para conseguir chegar ao resultado, é muito importante para a gente. Eu lembro até um congresso em Porto Alegre, em que eu discuti com um intensivista cardíaco da Austrália, que foi uma coisa bastante boa para o meu serviço, porque eu implementei alguns protocolos, mantive um contato com ele, implementei alguns protocolos. Então, o objetivo é ter uma discussão ativa. Se vocês viram que a gente tem 30 minutos de discussão, as palestras são até relativamente pequenas, né? Mas tem 30 minutos para discussão, para justamente vocês colocarem suas dúvidas e a gente conseguir interagir bastante com a plateia. Esse é nosso objetivo, tá? Nós vamos ter, no meio da manhã, um coffee break, depois teremos um almoço que vai ser nesse andar mesmo, aqui nesse andar mesmo. O almoço está incluído na inscrição, estão todos convidados, vai ser um prazer ter vocês almoçando com a gente. E, à tarde, teremos um outro coffee break. Nós estamos pensando amanhã, como a gente recebeu solicitações de conhecer o nosso serviço, estamos pensando já em botar uma van amanhã, que é à disposição de todo mundo que quiser ir. Por favor, se inscreva lá na recepção aqui do nosso pequeno congresso, para a gente ter ideia do montante de pessoas para irem, depois do final do congresso amanhã, até o nosso serviço, que é um pouquinho longe, uns 40 minutos, a mãe não tem trânsito, talvez uns 30 minutos, para vocês verem como a gente está funcionando, como são nossas instalações, nosso equipamento, enfim, fiquem à vontade e se inscrevam, tá bom? E qualquer dúvida, é uma coisa bastante informal, bastante interativa, eu quero que vocês levantem a mão, ou nós vamos ter pessoas circulantes, se alguém for mais tímido, quiser passar um bilhetinho, fiquem à vontade, tá bom? Agora eu vou chamar o Dr. José Maria, que não queria falar, mas vai falar, que é o outro fundador, sócio fundador da Perinatal, para falar algumas palavras.
Bom, eu acho que já Sandra falou bem do simpósio, e o que eu tenho que falar aqui é um orgulho muito grande que a gente tem desse serviço hoje. A gente tinha uma dificuldade muito grande no Rio, como neonatologista, eu e o Manel somos neonatologistas. Durante muitos anos, a gente perdia o cardiopata. Internava o neném, as coisas mais simples que tinham para operar, operava, morria, não funcionava, ia para São Paulo, morria. Então, nós tínhamos uma dificuldade. Isso era um problema para nós na perinatal, até o dia que nós resolvemos montar o serviço. Montar o serviço e começar a formar uma experiência e ter resultado. A gente via as outras pessoas tendo resultado em outros lugares e a gente não tinha. Então, eu me lembro muito da angústia que a gente tinha com esse pequeno bebê, que a gente nascia muito. Nós temos um serviço grande, sempre tivemos, de maternidade. Então, hoje é um orgulho muito grande que a gente vê esse serviço onde ele está hoje. E a gente quer fazer cada vez melhor. Eu falo sempre para a Sandra, nós temos que trazer o que tem de melhor lá fora. Vamos olhar, como ela diz, estamos fazendo um simpósio, vamos visitar o que é que está disponível que a gente pode trazer para estar realmente na frente do conhecimento aí. E vocês veem hoje que a medicina está numa revolução aí, do ponto de vista da forma do paciente se relacionar. Nós hoje estamos sendo... Existe uma empresa que está nos oferecendo um programa de consulta à distância, em que ela vai instalar uma plataforma lá e a gente vai consultar para o Brasil inteiro. Então, são coisas que vão dar a oportunidade de muitas pessoas no país que não têm acesso a possibilitar o uso desse serviço. A gente está fazendo um convênio agora com o Ministério da Saúde, em que a gente vai poder operar ao nível do governo federal. Qualquer criança, estiver lá no Pará, estiver lá no Acre, estiver lá em Minas, onde que ela estiver, esse programa vai nos dar suporte para trazer essas crianças. A gente fez uma das coisas que esse programa trouxe para o Rio de Janeiro também, foi isso. O Manuel mencionou que a gente tem um convênio com a Secretaria de Saúde, da mesma forma que morria na perinatal, morria nos hospitais públicos. Os hospitais públicos mandavam 8, 9 crianças por mês para São Paulo e as outras 20 ou 30 morriam, porque não tinham assistência. Então, quando a gente começou a operar, e nesse ritmo de 20 crianças mês, 25 crianças mês, eu acho que nós prestamos um serviço excepcional para a saúde pública do Rio de Janeiro, que não tem condição. Existem alguns hospitais no Rio que operam, claro que eles operam, mas não dá o volume que é necessário para a demanda dessas cardiopatias. Então, há pouco tempo eu li um artigo muito interessante numa revista de negócios, mas que ela falava assim, da reflexão, para que serve o seu negócio? Entendeu? Qual é que é o propósito do seu negócio? E quando a gente pensa aqui, no vídeo, o Manel menciona alguma coisa que a perinatal é um lugar em que as famílias realizam um sonho. Eu acho que hoje a gente tem como propósito, enquanto hospital, está melhorando a vida das pessoas. Na realidade, ele vem se tratar, mas o objetivo maior é que você proporcione saúde. E eu fico muito orgulhoso quando eu vejo um time como esse nosso, excepcional. Está a Júlia ali na minha frente, estou até... Nós temos aí um time excepcional, vocês estão de parabéns, e parabéns pelo simpósio. Por favor, chama o professor para a aula.
Agora nós vamos chamar nosso primeiro palestrante, Dr. Gregory Hammer. Ele é professor em anestesiologia e pediatria da Universidade de Stanford. É uma pessoa que trabalha em terapia intensiva cardíaca, pediátrica, é anestesista de cirurgia cardíaca pediátrica e também da parte da UTI cardíaca pediátrica. Eu gostaria que o Dr. Gregory Hammer, would you please?
Can everybody hear me if I don't use the microphone? Or should I use the microphone?
Actually, you have to use because it translates.
Okay, all right. Well, I would like to thank Dr. Sandra very much for inviting me. I've been to Rio many times, and it's a great pleasure. And I'm particularly grateful for the cool weather, because usually it's like 40 degrees when I'm here, which is too hot for me. So as Sandra said, I'm a pediatrician, anesthesiologist, intensivist, and I practice pediatric cardiac anesthesia and intensive care. And I have a laboratory where we do developmental pharmacology research. But I was asked to talk about a single ventricle physiology, and we have a pretty short time. So what I'd like to do is go pretty quickly through some anatomy and physiology, and then really talk just briefly about some data related to balancing the circulation and pharmacotherapy for supporting these babies. So I thought I would give you, see, are we working here? So I don't think this is advancing. Thought I would just give you a few seconds to memorize these abbreviations, because I've noticed that in Brazil, everything is backwards for us. So if you just take 10 seconds to memorize everything on this slide, we'll have no problems. Okay, everybody got that? All right. Actually, I think your system makes more sense, because you say the word that the noun is first. So then we know what we're talking about. We put it at the end, so the listener is in suspense. No, it's still not working. Okay, so let's talk a little bit about single ventricle anatomy and physiology. Hypoplastic left heart syndrome is kind of the model for single ventricle anatomy. So we'll talk most about that. But the same principles apply to hypoplastic right heart or various other types of single ventricle anatomy. So we'll talk about making the diagnosis, immediate management strategies, primarily with regard to the surgery. We have many people in the US doing classic Norwood and others doing the Sano procedure. It's working?
Sorry, yeah.
I think you, oh, maybe on the edge. Yeah, okay. Or maybe you have to be Brazilian. Okay, so this is what we'll talk about fairly briefly. I'm going to have to ask you to do this. There we go. Okay, maybe I just have to be closer.
Yeah.
Okay, so many of you or all of you are very familiar with hypoplastic left heart syndrome. You have very small left ventricle, small or atretic mitral and aortic valve, and communication between the left and right atrium. We also have diagnoses such as double inlet left ventricle, where, sure, we have similar physiology, but with some important differences in terms of pulmonary venous drainage, for example. Okay. So with regard to hypoplastic left heart syndrome, you have the key elements where the right heart, or in cases of double inlet left ventricle and other hypoplastic right side diseases, single ventricle supporting both systemic and pulmonary circulation. In hypoplastic left heart, you have to have a good size atrial communication. The flow to the coronary arteries is retrograde down the hypoplastic ascending aorta. And importantly, the relative flow between pulmonary and systemic circulations is dependent on the respective vascular resistances. So there's a lot of physiology that we might be able to manipulate, sometimes for better, sometimes for worse.
Forward, back, immediately.
Okay, good, okay. So how do these babies present? As you know, they present in a variety of ways. They may be pink, but have diminished pulses and systemic circulation because they have too much of the blood going to the lungs rather than to the body. So they are very well saturated, but their blood pressure and systemic circulation are diminished. Or they can sometimes have very good systemic perfusion, but they're very blue. So much of the blood is going to the body, not enough to the lungs, and so they may be very cyanotic, but with very good pulses initially. Of course, then they may deteriorate because the perfusion to the heart is with very blue, desaturated blood, and so they will eventually develop cardiac hypoxia. Okay. We have standard risk hypoplastic left heart babies. Of course, they're all high risk, but those that are especially at high risk are babies who are premature or small for gestational age, those who have aortic and or mitral atresia, and when the atrial septum is restrictive, that is the atrial septal defect is small, so the pressure on the left atrium is higher than the right atrium because pulmonary venous blood is going to the left atrium and cannot easily get across to the right side. Those babies are very sick and high risk. If they have an abnormal atrioventricular valve or if they have other congenital anomalies. So most of the infants are diagnosed in the first few days of life. They're often gray, and as I said before, they may be pink or they may be blue. Oftentimes they're pink in the beginning, but as the ductus begins to close, they desaturate and become very shocky. The diagnosis, as you all know, is made by echocardiography. We don't generally catheterize these babies. We have to evaluate the size and sufficiency of the atrial septal defect by using echo. And then, of course, we have to do a careful examination of the baby's body to make sure they don't have other congenital anomalies that babies with hypoplastic left heart syndrome or other single ventricle diagnoses are prone to have. So you can see here in the case of a restrictive atrial septum, that the key features are that there's really no left ventricular apex. If you can see the cardiac shadow amidst all of the whiteness of the lungs, the right heart border is very prominent. And in this case, because there's pulmonary venous congestion, there's a lot of pulmonary edema. And so these patients are in a lot of trouble. In terms of their immediate management, as you're all familiar, the ABCs of management are to avoid a very high inspired oxygen concentration, which will dilate the pulmonary arterioles and lead to pulmonary overcirculation. Saturation should be in the mid-70s to, at the very most, in the mid-80s. We don't want to overventilate these babies if we're mechanically ventilating them, because a low CO2 will also cause the pulmonary vascular resistance to be low. They may need fluid resuscitation. They have poor right ventricular function. They may need inotropic support. And this is one case where we use sodium bicarbonate to correct any lactic acidosis or metabolic acidosis, whereas I think in most of our babies and children, the use of bicarbonate is somewhat controversial because it may actually be injurious. In hypoplastic left heart syndrome and other single ventricle diagnoses, we're a little bit more aggressive with bicarbonate because when these babies become acidemic, there's a positive feedback loop or sort of a self-propagating cycle of deterioration, poor heart function, more metabolic acidosis, more heart dysfunction, et cetera. So we do try to correct the pH abnormality. So when the babies are born, if we think that if they're blue, they're desaturated, they don't respond to high FiO2, they should be immediately started on prostaglandin, of course, before the diagnosis is even made. We start usually at low doses and increase the prostaglandin if necessary. Of course, the risk of prostaglandin is apnea. So many of these babies are intubated because they have apnea or are at high risk for apnea related to prostaglandin. I think we are reluctant to intubate unless it's necessary, because usually when the babies are breathing spontaneously, they regulate their own circulation. So they balance their pulmonary and systemic circulation much better on their own than they do when they are intubated and having positive pressure ventilation. We can over-oxygenate them very easily or over-ventilate them very easily. And also the effects of positive pressure in the chest may not be good for their circulation. As you know, these babies are going to have staged surgeries, starting with the stage 1 palliation. They may need a balloon atrial septostomy if the atrial septum is restrictive. We usually do this with echo guidance in the neonatal intensive care unit. We can talk a little bit about the classic Norwood with a Blalock-Taussig shunt versus the Sano operation, where there's a graft or a conduit from the right ventricular outflow tract to the pulmonary artery system. And then, of course, they will go on to need a Glenn operation and ultimately a modified Fontan. And there are also a couple of choices in terms of the surgical approach to the Fontan operation, whether it's extracardiac connection between the inferior vena cava and pulmonary arteries, or whether it's baffle-type intracardiac repair. So you can see on the left-hand side is the classic Norwood. You can see the neo-aorta. In our case, we use a combination of homograft and possibly some Gore-Tex, but it's normally mainly a homograft, which I understand you don't have access to in Rio, unfortunately. And also on the left, you see the connection between the aorta or subclavian artery and the right pulmonary artery. On the right-hand side, you see the Sano modification, where the systemic to pulmonary blood flow is through a graft from the right ventricular outflow tract to the pulmonary artery. And in our case, we use a valve. So again, it's a homograft, either aorta or pulmonary artery from a cadaver with the aortic or pulmonary valve. So the reason that this operation, I think, has become popular is because the diastolic flow is diminished when the homograft valve closes during diastole. So this tends to preserve diastolic blood pressure and ideally will augment coronary artery perfusion. So here you see with the classic Norwood, the Blalock-Taussig shunt, and one of the problems with this is that because there's no valve in the shunt, there's a lot of diastolic reflux back into the pulmonary arteries, or rather the aorta during diastole, and this lowers diastolic blood pressure and coronary artery perfusion. Whereas in the Sano, again, we use a valved conduit, which is homograft, and that is ideally better because of a reduction in diastolic runoff. We'll talk a little bit about studies that are comparing the Sano with the classic Norwood that are ongoing in the United States at this time. So the basics of perioperative management, both preoperative, intraoperative, and postoperative, are well known to you all. Of course, we monitor everything possible. We use the near-infrared spectroscopy. I don't know if you have this here. Yes, okay. So we typically put the NIRS on the forehead in the operating room and also on the flank. And it's very useful. Sometimes, for example, in the operating room, I'm noticing that the oxygen saturation is going up. And this may be the first clue that the baby's being over-circulated. Or I may notice that the NIRS is going up. So everything else seems the same, but the NIRS number for the brain is going up. There's too much systemic blood flow. So this is a very useful tool when things are changing very much, in particular in the operating room and in the early post-operative period. The other thing that has been monitored, let's see if I have a pointer here. On the very bottom is the systemic venous saturation. So some centers have placed an oximetric catheter in the superior vena cava to monitor this continuously. This is not commonly done anymore. I think Children's Hospital in Milwaukee, Wisconsin promoted this, Dr. Hoffman, and we can talk a little bit about why that might be helpful, but we are not doing this at the present time. We have a whole variety of pharmacologic agents that we can use to augment cardiac output and help manipulate the balance between pulmonary and systemic blood flow. So you're familiar with all of these drugs here, and there's been a lot of debate in the United States and elsewhere as far as which drugs are better. So one interest of mine for a very long time has been the use of dopamine. I'm not a big fan of using dopamine, and we'll look at a couple of studies that show that dopamine may not be helpful. But for some reason in this world of perioperative care and congenital heart surgery, there's a lot of culture. So many people do things the same way because that's the way they do it. That's the way they've always done it. But I think we have to really look closely at the data when there are research studies to help guide our therapy and be open-minded about changing what we're doing. That's called progress. So for mechanical ventilation, both preoperatively, when the babies either have some pulmonary edema, maybe they have restrictive atrial septum, or they're over-circulated and have too much pulmonary blood flow and have pulmonary edema, or because they have apnea during prostaglandin infusion, we do intubate them. So both preoperatively in that case, and of course during surgery and after surgery, there are important principles of mechanically ventilating these babies. We use what we call an open lung strategy, which I think is probably familiar to all of you. We use just enough PEEP, positive end expiratory pressure, to keep the lung open. And we want to use very small tidal volumes so that we don't have a very high intrathoracic pressure during inspiration. We want to use the air if possible. We have a saying, we always say room air. I don't know if this is, but I correct everybody who says that because it's actually coming from a tank. So it's tank air. I'm very much opposed to the use of unnecessary four-letter prefixes and suffixes. So room before air is unnecessary. It's just air. When the residents say, oh, the patient's on room air, say, well, what if we take them to the elevator, or we go on a field trip outside? It's outside air, it's elevator air. There's elevator music, but there's really no elevator air. So room is not necessary. It's just air. For babies who are over-circulated, we have had several strategies. We can either let the CO2 be higher. This should increase pulmonary vascular resistance and help systemic blood flow. So we can either use underventilation, or we used to have CO2 available in a tank. It was tank CO2. And we could use a little inspiratory CO2 to increase pulmonary vascular resistance. But this has kind of fallen out of favor for reasons I don't understand. I like using inspired CO2 when necessary. But the other treatment for overcirculation, of course, if the baby's blood pressure, systemic blood pressure is good, is to reduce systemic vascular resistance with drugs, such as milrinone and other drugs. The other thing we can do if the baby is overcirculated, the oxygen saturation is high, they're on air, we can actually use nitrogen to lower the FiO2 to perhaps 0.18, but that also lowers the cerebral saturation. So I think it's better to use CO2 and use an increase in PEEP, positive end expiratory pressure, which will decrease pulmonary blood flow to some degree. Usually it's a surgical problem though, so if the baby is really overcirculated, despite all of these things, they need to go to the operating room. I think in terms of sedation and analgesia, we're all using probably the same drugs, fentanyl, maybe a benzodiazepine. I think the use of dexmedetomidine has become much more popular. In our center, we leave the chest open after surgery for 1 or 2 days. We don't always keep the babies paralyzed, but if they're moving around, their blood pressure is low, we can't use a lot of sedative and pain medications, then we may paralyze some of these babies. We tend to keep their hematocrit very high. It's just what our surgeons prefer. So we tend to transfuse and keep the hematocrit close to 50%. This is not something I think that everybody does in the US to keep the hematocrit that high, but that's part of our strategy to increase oxygen delivery to the tissues. We try to avoid unnecessary stimulation, such as deep suctioning of the trachea. So we normally will only pass a suction catheter to the end of the endotracheal tube, not further, to stimulate the carina, which generates a lot of sympathetic response, which can be adverse for these babies. So we have cases where the cardiac output is low, and even though the saturation is in the 70s, the blood pressure is low. So it's not a matter of pulmonary overcirculation. It may be ventricular dysfunction due to cardiopulmonary bypass. The single right ventricle is not as well designed for maintaining cardiac output as the left ventricle. So babies with single ventricle who have a left ventricle are a little bit better off than those who have a single right ventricle, especially over time. There may be limitation in coronary artery flow. There may be too much pulmonary blood flow causing low blood pressure in the systemic circulation. So it's very essential to balance the circulation. Again, we have a large selection of drugs that we can use. I want to just say a little bit about dopamine. This is an older study, but I think still very important study done by Dr. Gia Lee in Toronto. And basically, she measured using a metabolic machine connected to the baby's endotracheal tube, all of these indices with echo and with measuring metabolic function. And she measured these at baseline while babies were receiving dopamine after surgery, and then she continued to monitor the babies when the dopamine was weaned off. So this is sort of during and after dopamine, looking at all of these physiologic parameters. And I just want to draw your attention to the fact that when they turned the dopamine off, the cardiac index did not change. So it seemed as though the dopamine was not necessarily supporting cardiac function. But instead, what she noticed is that the heart rate, when the dopamine was discontinued, actually dropped, and also the oxygen consumption dropped. So the implication is that dopamine was causing no increase in cardiac function, but was causing an elevated heart rate and increased myocardial oxygen consumption. So in other words, it was the oxygen supply and demand was adversely affected by dopamine. So this is just in summary how we should really question the drugs that we're using. And I don't know whether you're using dopamine routinely, but again, we talk about the culture in perioperative cardiac care, And so we still use a little bit of dopamine, but we don't usually go more than 5 micrograms per kilogram per minute. But our usual cocktail of drugs coming off of bypass is 3 of dopamine, 3 micrograms per kilogram per minute. Usually we load the patient with milrinone on cardiopulmonary bypass, and we run them at an infusion of 0.25 to 0.5 micrograms per kilogram per minute, and if necessary, 25 or 0.025 or 0.03 micrograms per kilogram per minute of epinephrine. So we know the factors that cause a change in pulmonary and systemic vascular resistance. And I just want to summarize what Dr. Lee's study showed. If you look on the graph on the left side, you see a very close relationship between oxygen delivery and systemic vascular resistance. So when the systemic vascular resistance goes down, oxygen delivery is improved. And you can see this is a very tight, close relationship. But when you look at the relationship between pulmonary vascular resistance and oxygen delivery, it's sort of like a scattergram. So this shows us, I think, it's more important to manipulate the systemic circulation than the pulmonary circulation. So we're really more focused, if the baby is over-circulated, on lowering the vascular resistance instead of trying to increase the pulmonary vascular resistance. I'll just say very briefly, I think I only have a few minutes left. Most of you are familiar with the Fick equation. We can manipulate this equation in this fashion to measure or calculate the relationship between pulmonary flow and systemic flow. And the variables are on the right side of the equal sign. It's the systemic oxygen saturation minus the mixed venous, but really we're looking at the SVC, or superior vena cava saturation, divided by the pulmonary venous saturation minus the systemic saturation. And we're guessing what the pulmonary venous saturation is. And this is often, we may be wrong about that number. So when we look at the oxygen saturation on the pulse oximeter, we may be unsure about what the QPQS is. So we want the saturation to be maybe 75%, but sometimes there's overcirculation, but there's pulmonary edema. So the pulmonary venous saturation is lower than we think it is. That's why the saturation looks good. So you can have a saturation of 75% even though there's too much pulmonary blood flow and not enough systemic blood flow. So we have to be a little bit cautious in looking at the oxygen saturation and thinking that this is a perfect measure or surrogate measure of pulmonary vascular resistance. So just assuming if the oxygen saturation is about 80%, and if we assume that the pulmonary venous saturation is high, close to 100%, and the SVC saturation we usually assume is about 25 points lower than the systemic saturation, then using this equation, we would come up with a QPQS of about 1.4 to 1, which is close to where we want it. So this is with a saturation by pulse oximetry or by co-oximetry of 80%. I won't go through all the bullet points on this slide. I just wanted to say a word about the drug therapy that we use. And I said before that we are now more focused on lowering the systemic vascular resistance if the patient is overcirculated, not so much trying to increase pulmonary vascular resistance. So this is from George Hoffman's group in Milwaukee in Wisconsin, in the sort of the middle of the country in the US, which is where I'm from, Chicago. And basically, they showed the benefit of lowering systemic vascular resistance during and after bypass with a drug called phenoxybenzamine, which is a vasodilator. And they showed that in the babies who got phenoxybenzamine, they had less variation in oxygen delivery over time. So it was easier to keep the circulation balanced when they lower the systemic vascular resistance. So that is our target. Although we do not use phenoxybenzamine, we tend to use a calcium channel blocker, which I don't think you have here, but it's It's a short-acting calcium channel blocker in addition to milrinone. Finally, I'll just say a few words about comparing the classic Norwood with the Sano operation. There's a big study ongoing in the United States. I don't have time to go through all the details, but of course I'm happy to share my slides with anybody who wants them. But basically, when patients are randomly assigned to have a classic Norwood versus a Sano operation where there's a valved conduit from the right ventricular outflow tract to the pulmonary arteries, we thought the Sano would be much better. The patients who have a Sano compared to classic Norwood do a little better for the first 12 months. But after 12 months, they don't seem to have any improvement in longevity or survival. And it may well be because, so this is just a curve showing that in the first 12 months, the patients with the Sano do better. They have increased survival on this Kaplan-Meier curve. But eventually, even after they've had the Glen, they're no better off. So this is well, I won't really talk about the Fontan. So I'll just say in conclusion about the Sano operation, we are using, all our surgeons do the Sano procedure for all the patients. Leave the chest open for 1 or 2 days, then close the chest. So they prefer the Sano, but the data from this longitudinal study are unclear. It's certainly not what we would call a magic bullet to do the Sano, even with a valved homograft, compared to doing a classic Norwood. So I think whatever the surgeon is more comfortable with is probably what will give the best results. Questions include the role of NIRS. I think we use it. The data don't necessarily show that it improves outcomes, but I think it's a good trend monitor. As I said, sometimes when the NIRS changes, it's the first signal to me that I'm overventilating the baby, for example, or maybe underventilating the baby. We talked about using a low FiO2 to increase pulmonary vascular resistance versus using inspired CO2. I think inspired CO2 is better, but we're not so focused on the pulmonary vascular resistance anymore. We're more focused on the systemic vascular resistance. Also, it's important to avoid hyperthermia, and it's very important where we're measuring the patient's temperature. So tympanic membrane or nasopharyngeal temperature probably is best for reflecting the actual brain temperature, which is mainly what we care about. So we have to be sure that we don't let these patients get fever, because they will be more likely to develop adverse brain outcomes. So I think that hopefully we've learned a little bit about making the diagnosis, immediate management strategies, the difference in surgical approaches, postoperative management, our focus on systemic vascular resistance for balancing the circulation. And with that, I will stop, and thank you very much for your attention.
A gente precisa de mais microfones aqui na frente, por favor. Eu acho que foi excelente. O Dr. Greg deu uma passada sobre todo, acho que só mais um, sobre toda a fisiologia do ventrículo único no pré-operatório e também no pós-operatório. Eu não combinei com ele esse negócio da dopamina. Thanks, Greg, that you talked about dopamine, because I hate this. I mean, I don't use it for years. In every meeting that I go, I talk about this, and people don't believe me, but now they will. E eu gostaria que a plateia fizesse algumas perguntas, porque aí a gente tem várias questões, né? A questão da fisiopatologia em si, e também a questão de todo o pré e pós-operatório. Eu queria que vocês levantassem algumas dúvidas. Eu estou aqui cheia de dúvidas, mas eu gostaria que vocês levantassem alguma.
Eu vou fazer a pergunta em português. Ele está recebendo a tradução lá? Eu vou fazer a pergunta em português? É. Ok. A pergunta é o que a gente pode prever do tipo de paciente que a gente vai ter com os exames antenatais? A gente faz muito eco pré-natal hoje, e a gente identifica muito dessas crianças dentro do útero. Se você ajuda muito para você saber qual é o tipo e qual é o approach que você vai ter imediatamente após o nascimento?
Well, do you have a specific concern about the ultrasound findings in the prenatal exam?
Yeah.
Is there something specific?
Yeah, like if it helps when
Uh,
the baby is born.
Well, first of all, making the diagnosis that the baby has congenital heart disease is very
Yeah.
important. And specifically for hypoplastic left heart syndrome, of course, it is important to look at the specific anatomy. So we may be able to diagnose a restrictive atrial septum, and therefore we are ready.
You're hearing your own voice.
Oh, sorry, yes. So therefore we can be prepared to do an immediate balloon septostomy as soon as the baby is born. So yes, I mean yes, for sure. I mean, if we have a single ventricle physiology, then we're ready with the prostaglandin, absolutely. So no, I think this is critical component of managing the patient. And also, of course, I think as in your center, if an intrauterine diagnosis is made of congenital heart disease, it's better to transport the mother to your center rather than wait till the baby is born, and then you have a lot of disadvantages. So very important.
Quem vai falar é o doutor Eduardo, que é de Colorado, também é um dos nossos convidados internacionais. Ele é chefe do CTI Cardíaco de Colorado, também é autor de um livro de terapia intensiva, cardiologia pediátrica. Enfim, ele será melhor apresentado, só para vocês saberem.
Muito obrigado. Português or English, whatever.
Up to you, but
Well, let's go for English.
how about French? No.
Can do that too.
This guy speaks 8 languages.
Yeah, nah, come on. No, it's just, I just want to add a philosophical comment to your comment, which is the need for a tight collaboration when in these circumstances between neonatology, cardiology, intensive care, etc. I think the most important point of success when receiving these babies upon delivery is this collaboration. And as a matter of fact, you can also think about processes like a modified exit procedure for patients who have more than restrictive absent intra-atrial communications, where you also bring, of course, all the perinatologists and so we can go for a C-section, keep the baby on fetal circulation, insert all the necessary gear, and from there, next door, going straight to the cath lab or else going on that type of things. But to say that this collaboration is really key wherever protocols are used in whatever institution. So that's what I wanted to say. And then since I have the microphone, I don't know if I can ask a question, which is, what is your opinion, or let me reword this. Do you think there is room for hybrid approach, call it complete or partial, and even transplantation for patients with hypoplastic left?
Yes, I'm sorry. I didn't really have enough time to talk about that, but I agree that I should have mentioned the hybrid procedure. This was really pioneered by Mark Galantowitz in Ohio at Nationwide Children's Hospital. I was lucky enough to visit there, and as a visiting professor, first they had no big surgeries that day, but during the morning when I was talking to some of the faculty, they said, "Oh, Dr. Hammer, we have a hybrid." So I went to the operating room and made a small incision, and the cardiologist came into the room to help with the pulmonary artery bands, and the procedure took 45 minutes, and the baby was extubated on the table. It was really impressive. So that is their procedure of choice. For us, we reserve the hybrid for situations where cardiopulmonary bypass would be too risky. So the hybrid, one of the advantages is you do not have to put the neonate on cardiopulmonary bypass with all the risks associated with cardiopulmonary bypass. But the second stage operation is a much bigger operation, of course, if the patient had a hybrid type repair initially. So the neo-aorta reconstruction, that happens at 4 to 6 months of age. So I think it's somewhat controversial as to when a baby should have a hybrid procedure and when they should have a typical Norwood or Sano hypoplast repair. And it's up to the surgeon. I think for us, we have a hybrid procedure room, but we're not doing that many hybrids. The surgeons would prefer. How are you doing in Denver?
Well, we have the same approach, I guess. As you said it very well, I think what matters is what you do well. And in centers where the outcomes for Norwood, call it Sano or traditional, are in the high 90s in terms of survival, there's not a lot of appetite for hybrids. But we do reserve it for patients, as you were saying, 1 kilo baby or comorbidities or Jehovah's Witnesses sometimes. And then we do have a program for neonatal transplantation, which means some of these babies will need at least a partial hybrid, meaning just ligating the PA arteries without even inserting a ductal stent, just keeping the baby on prostaglandins. But that's not a lot of patients.
Yeah, we have a pretty busy cardiac transplant center, but it'd be very rare for us to offer that to a family with a neonate with hypoplastic left heart syndrome because, as you said, for most of the patients, the surgical results are very good. So whereas I think at Loma Linda in Southern California, they do more neonatal heart transplants for hypoplastic left heart, but I think this is unusual.
I think it started when they didn't have a good results for the Norwood and the hybrid procedure, so they would offer the transplant. But nowadays, it's different.
Yeah.
Alguém tem uma...
Posso falar?
Pode falar, Cláudia.
Eu sou anestesista do grupo da perinatal e nós fazemos anestesia bem semelhante ao que você apresentou e atualmente nós estamos mais focados na questão da proteção cerebral. E além do controle da temperatura, do uso do NIRS, vocês têm algum protocolo de proteção cerebral? Vocês usam alguma medicação para prevenir as convulsões no pós-operatório?
No, this is another element I did not really have time to discuss, but as far as intraoperative management, deep hypothermic circulatory arrest compared to low flow, continuous perfusion, cerebral perfusion. I don't know how your surgeons are doing this. Are using circulatory arrest?
Yes.
Or low flow?
Low flow.
Yeah. So I think when I trained at Children's Hospital in Philadelphia with Dr. Norwood, he was our chief surgeon, everybody had circulatory arrest. And so we used our protocol for managing seizures, which were common after deep hypothermic circulatory arrest, was giving small doses of phenobarbital if the patient had seizure activity, so not as a preventive measure. But with low flow cerebral perfusion, we see very infrequently seizure activity. So in terms of brain protection overall, I think we do what everybody does. We cool the babies to 18 or 20 degrees. We have low continuous cerebral perfusion, low flow. I don't think that there's been any good demonstration that any drug is particularly helpful. I mean, the babies are anesthetized, so You know, we use anesthetic vapor on the bypass machine, isoflurane, probably you do also. Beyond that, you know, the babies get a big dose of corticosteroid on bypass. I don't know if this has any benefit for the brain, but we do it.
Não.
So those are our strategies. We use hypothermia, low flow cerebral perfusion, corticosteroids in case that helps. We do NIRS monitoring, of course.
Yes. Thank you.
A long time ago, there was a paper in the New England, many years ago, from Dr. Andrade. Remember that, with high doses of fentanyl.
Yes.
It's
He's my colleague at Stanford now. Sonny
Is that right?
Andrade, yeah. Well, what he was looking at was basically very light anesthesia with neuromuscular blockade, of course, versus a much deeper opioid-based anesthetic. And the patients who had the deep opioid anesthetic had better outcomes. But I think this is old stuff by now. I mean, nobody would give a little bit of anesthesia and paralyze the baby anymore. I mean, we're very much aware that we need to give a lot of usually opioid-based anesthesia to block the sympathetic nervous system and, you know, perhaps offer brain protection as well.
Ninguém da plateia tem dúvida nenhuma? Do you still use phenoxybenzamine?
We don't use phenoxybenzamine. We never did, but I think the point of Dr. Hoffman's study is to show that by lowering systemic vascular resistance, the babies were much more stable. They had much less sort of up and down circulatory alterations, and whereas phenoxybenzamine is a long-acting drug, so they just give one dose. We're using, I think, like you are, milrinone. So we load the baby with milrinone on cardiopulmonary bypass, and then we use a continuous infusion of milrinone. And if we need more afterload reduction, or we need to lower the systemic vascular resistance more, then we use a vasodilator by continuous infusion. The thing with phenoxybenzamine is you give one dose, and then you're stuck with that, because it's a very long-acting drug. So we use short-acting systemic vasodilator therapy.
Yeah, they had the babies with hypotension for a long time and had to use a vasopressor epinephrine to have it back. Nós temos 1 minuto, ninguém tem nenhuma dúvida. Tem um pessoal de Minas aí, não tem? Como é que vocês manuseiam no pós-operatório de Norwood os pacientes?
Doutora Sandra, bom dia.
Bom dia.
Obrigada. Essa equipe toda aqui é de Minas.
Sejam bem-vindos.
Muito obrigada. Nós somos da Santa Casa, de Belo Horizonte. Nossos pacientes são 100% SUS. A nossa experiência ainda com a Norwood, quando eu fui vendo, é de chorar, porque a nossa mortalidade ainda é quase 100%. Agora demos alta num bebê, mas a aorta era 5 milímetros. Então, isso a gente já consegue manusear melhor. Essa semana tivemos um outro, anteontem, 4 milímetros, mas já chegou do bloco já para terminar de falecer dentro do CTI. Então, a nossa experiência com a Norwood é muito ruim.
Mas nós começamos assim também, todo mundo começa assim.
Então, a gente acredita e estamos aqui para poder aprender, para ver se a gente consegue fazer melhor. Por isso a gente agradece a oportunidade.
Tá ótimo, querida. Obrigada. Mais uma e acabou.
Vocês usam ácido tranexâmico nessas crianças ou vocês usam Epsilon? Qual é a estratégia de antifibrinolítico para diminuir o sangramento?
Você pergunta entre o Epsilon e o
ácido tranexâmico.
Yes. We use tranexamic acid, yeah.
And which dose?
Don't ask him those, because I know he has a lot of fellows to do that for him. You know, he just say, do it. Follow the protocol.
Porque porque existia um protocolo anterior de 100 miligramas por quilo. E
Right.
está associado à questão de convulsão no pós-operatório. Em últimos trabalhos que nós fizemos um levantamento, e nós estamos atrás de iniciamos uma diminuição dessa dose, atualmente nós estamos em 50 miligramas por quilo. Então, a gente queria meio ter uma referência aonde vocês estão, em 100 ou em 50?
We use high dose, so we use 100.
É.
We also use a lot of platelets. So when the heparin is reversed, we always give platelets, and we're very lucky to have reduced volume platelets. So we have the equivalent of 6 units of platelets in 50 mLs of volume. So I'd be interested to hear how you guys are doing it, but and maybe you're not all that familiar with what's happening in the OR, I don't know, because...
Oh, no, I am.
Yeah, so we use, we have volume reduced platelets, so we use tranexamic acid, and then we routinely give 1 low volume unit of platelets equivalent to 6 units after we reverse the heparin.
Oh, you do?
Yeah, but I know that not everybody has the kind of
We have.
volume reduced platelets available. You do have?
Yes,
Yeah.
we have.
I mean, that's been a major advance because giving, you know, non-volume reduced platelets is too much fluid.
We do the same, but we did move to 50 milligrams, so, but arbitrarily, not based on data. So we prefer to repeat the dose if clinically necessary, then give the high dose. But
Yeah.
again, the data is totally equivocal. I mean, it's a matter of choice.
Ok, thank you.
If I know that was the last question. This is not a question, that's just a provocative comment about the use of vasopressin in the post-op of Norwood, which we can discuss at the coffee, you know.
Yes, because it's a good discussion. Yeah. Nós vamos para a próxima, então, agradecer aqui ao Dr. Gregory Hammer pela brilhante palestra dele. Thank you, Greg. Thank you.